Hi, my name's Tony Blakely. I'm a research professor at the University of Otago, Wellington, and I've recently led a team that have been looking at the cost, the effect, and then the cost effectiveness of cancer care coordinators for stage 3 colon cancer only, and that's important. My team's shown on this slide here in front of you, and it's been a groundbreaking for us as a program. This is the first type of analysis we've done in the cancer space, and we've spent some considerable time on it. So essentially the context here is that cancer care coordinators are a priority for the current government, with $33 million announced for faster cancer services, better cancer services in the budget in 2012, and $16 million of that for cancer care coordination, which, interestingly enough, once we started working on this, there was not a lot of consensus in the sector as to exactly what that service would look like, what these people would do, and indeed perhaps some of you in the audience have been involved with helping us specify that and perhaps developing your own models further. So if you're going to do an evaluation about this sort of thing and try and work out the health benefit, you actually need to quite carefully define what the intervention is. Here is our definition. It's somebody who provides information support, psychosocial support, navigates people through the care system, because it's quite complex with a cancer when you've got to coordinate surgery and chemotherapy in this instance, but also radiotherapy, preventing people falling between the cracks. They also act as a point of contact for patients and health staff, and they coordinate and track the referrals and act on delays. Now, whenever you're doing this type of evaluation, you define the intervention, but it's actually even more critical as to what you're comparing it to. And what you're comparing it to, in New Zealand at least, varies by DHBs. Some DHBs have care coordination services in place, some don't. So we had to define our own comparator that was a rough average across DHBs and lined up a little bit with some of the evidence and literature and expert knowledge we used to parameterize our model. This is how we defined the comparator. Essentially, a bit of an average across DHBs based on the consultation that Lucy and Rachel led. Ad hoc patient needs assessment by nurses, surgeons, other health professionals at varying points, not just one person, but a range of people doing it at various points. Often uncoordinated, not always, but often uncoordinated, and no one individual being responsible for tracking referrals, investigations, or appointments. Now, how can a care coordinator make a difference? And when I say make a difference, I mean actually change somebody's quality of life or length of life. Well, essentially 3 ways. And what I've got here is a little diagram with a D, an S, a CS, and a CE. D stands for diagnosis, S stands for surgery, CS stands for chemotherapy start, CE for chemotherapy end. And there's 2 little boxes down there. One is DC, which stands for death from that cancer, in this case colon cancer, and DOC stands for death from other causes. And what happens is you get to the diagnosis point and you've got 3 events that may occur next. You may get to the surgery, you may die of the cancer, or you may die of another cause. And the next thing, if you get to surgery, say, the next you have 3 competing events again. You may get to chemotherapy start, death from cancer, death, on and on it goes. And this is how we model it. The reason I show this is because we use something called discrete event simulation. It's a detail not particularly necessary today, but it just models time to event. And where the benefit of care coordinators may come is in 3 places: reducing the time to surgery, increasing the coverage of and reduced time to chemotherapy, and possible improvements in quality of life. So those are the ways that we try to conceptualize, well, that's how we conceptualize the benefits and then parameterized our model. So this is a scary slide, and if I had an hour, I would explain all these cells to you. I don't, so I'm just going to show you that there's a lot of information that goes into this model. There's baseline stuff about the cancer incidence, about mortality rates, about disability rates, which is how we measure quality of life. Then there's all the stuff in the middle about the intervention effect, what survival advantage you get by getting surgery a bit quicker, what the actual effect of chemotherapy is, and then over on the far right is the actual cost of the intervention itself, which you'll notice if you're quick looking here, for example, surgery to chemo, it's only $5. Why? That's because when you put a care coordinator in, you also release other people to go and do other work. So the house surgeon, the ward clerk, whoever who was doing the coordination previously is released to go and do something else. And that's the idea of opportunity cost and moving things around and getting a net cost. So, no time for details in this presentation, so we'll keep on moving. And here you go, here's the results. Normally this takes me 50 minutes to get to this point. This is called a cost effectiveness plane. And what we've got here on the x-axis across the bottom is what we call HALI gains. HALI stands for Health Adjusted Life Years. So 0.1 of a HALI gain means that one person has gained perhaps 1 and a bit months, 0.1 of a year of quality life, life in a full status of perfect health, no morbidity. And what you've got on the y-axis is the incremental cost. In this case, it's the cost of cancer care coordinators versus our comparator. And this is the cost per person diagnosed with colon cancer, as are the HALI gains. Now what you see, there's a whole lot of green dots, and I think from this memory, I think there's about 2,000 or 1,000 dots on here, and that's for each iteration of the model because there's uncertainty in there, and each dot is representing the uncertainty across all types of New Zealanders, averaged over sex, age, ethnicity and deprivation. And what you can see is I've also plotted a dotted line on there which is called the willingness to pay threshold, and I've put on there $40,000 per HALI gain. So you'll notice that if 4,000 up on the y-axis, go across, hit the dotted line, drop down, it's at 0.1, so that's 40,000 per HALI gained. And that's a rule of thumb in that a country is often accepts as cost effective, spending the equivalent of the country's GDP per one HALI gained. And what you can see here is despite the fact there's considerable uncertainty, those green dots are all stretched on out there, but they're stretched out on the radius coming out from the origin, which means all the points fall beneath that willingness to pay. So it looks like actually it's a cost-effective evaluation here on average. So for colon cancer, stage 3 at least, we can do something about it. We appear to have a cost-effective evaluation by using care coordinators. Now, taking that graph and turning it into numbers, you may be familiar with some of these numbers. You can see here that the mean, that is the average incremental cost, is about $2,300. The mean or average HALI gain is 0.121, which is about a month and a half of life and full health. And that gives you a best estimate of cost per HALI of about $19,000. Cost per QALY is not too dissimilar to what we're doing, will be about the same, perhaps a little bit better because of the way we calculate HALIs. So that's the result. Now I've already mentioned this, so using the rule of thumb, you consider that to be cost effective, although of course any decision maker will tell you that whether or not you fund it depends on what other interventions you're considering at the same time and how much budget you've got. So these are guidelines only. Now, I've shown you the graph again now. This is quite interesting. So the green dots are on there again, which is averaged across all types of people. But the purple crosses now actually are not only allowing for uncertainty in the input parameters, what the hazard ratio reduction in mortality from the chemotherapy is, how many days quicker you get to your chemotherapy, all those things that are behind the scene in the models, those parameter uncertainty are captured in the green dots. The purple crosses now also include how the effect and the cost varies by types of people. People who vary by age, people who vary between Māori and non-Māori, by deprivation or by sex, because all those types of people and their combinations have different survival and different baseline time to getting the treatment. We know that from previous research. So we can see that actually when you consider population heterogeneity, there's a lot more spread in here. And just to give you an idea, here is a scatter plot whereby we actually break it into dots red for less than 65 and dots that are teal, green, for greater than 65. And you can see there's a clearly different positioning on the cost effectiveness plane, and the red dots are what we call further down to the southeast. That means it's more cost effective because they're further away from that willingness to pay, whereas the people greater than 65, they're kind of straddling that willingness to pay line, and it becomes a marginal call if you're brave enough as a manager to differentiate by age as to who receives this treatment. That's another issue, and I'll leave that for you. So if you're looking at this heterogeneity, that previous slide was just an example by age. You can see here, if you just look down the far right-hand column of the ISA, ISA stands for Incremental Cost Effectiveness Ratio, how much it costs at the margin for that extra HALI gain. There's the overall one of about 20,000 there. These are now expected values, so slightly different from the previous slide I showed you with numbers on it. Very little difference by sex. There's the difference by age, and it's far more cost effective for young people than it is for old people, and it's because old people, if you get them through to the treatment quicker, they stand to gain less because they're not around to survive as long if the cancer's cured. And then by ethnicity and age, we've got the results there. So essentially you can see here is that by ethnicity, the effect and the costs are not too different. We have looked at this in equity analysis too, and it's too long a story today, but this actually is probably a pro-equity intervention if you allow for background mortality. If you want to know more about this, contact us or go and look at the presentation on our website. Right, so implications for decision makers. For stage 3 colon cancer, it appears to be cost effective. And it probably is an inequality reducing intervention. We know that because the fact that Māori patients currently wait longer. So if you have an intervention that reduces your time to getting chemotherapy of the same percentage amount, it will tend to benefit Māori a little bit more. And if you're a decision maker and you're in a DHB with a cancer network, and you've already got a well-functioning, say, multidisciplinary team, i.e. you've already got reasonably good coordination services, we would expect that the marginal gain from cancer care coordinators will be a bit less. So you're not going to get as much heli gain, but also your costs will be a lot less too, because the major cost in here is not the cost of the nurse, it's the cost of the amount of chemotherapy that you generate, how many people you get to chemotherapy. So essentially on that cost effectiveness plane, your dot will move down closer to the origin. So your cost effectiveness will stay much the same, but actually the amount of benefit you get will be less because you're already getting people through the services. And if you're managing these types of services and you're really stretched and you've only got one care coordinator and you actually need 2, you might want to gently nudge them to working with younger patients, and because it's a bit more cost effective, but a bit of a tricky thing to do. But also, if you now think beyond stage 3 colon cancer, the things that we'd recommend you think about at the moment are put your effort where the treatments that you're trying to get people to are clearly shown to be efficacious and clearly length of life. The quality of life impacts are pretty small, so it's more about getting people to treatments that you know are effective and that will lengthen people's life. If you're doing that, you're probably on the right track with cancer care coordinators. Kia ora.